Welcome back. I'm the Intense MD, a double board certified intensivist, here to give you an inside look into the intensive care unit. Today, we're going to talk about a condition called atrial fibrillation or AFib. To start off, just a disclaimer that I am a doctor, but I am not your doctor. This video is to serve for educational purposes only. Atrial fibrillation is an irregular heartbeat or arrhythmia that occurs in the atria, which are the top chambers of the heart. Typically, the heart electrical impulses are in a very coordinated fashion. However, in AFib, they become disorganized and cause the atria to pump inefficiently and in a disorganized manner. This in turn can cause a heart rate to go up very quickly. It can also make it more difficult for the heart to pump blood effectively through the body. Some conditions you might hear about when referring to atrial fibrillation are paroxysmal AFib. This is when somebody's heart may go back and forth between a regular rhythm and atrial fibrillation. There's also a condition called AFib with RVR. RVR is rapid ventricular rate. So this is when somebody's heart rate gets dangerously high. What are the symptoms of atrial fibrillation? This can vary from person to person, and some people might not have symptoms at all. Many people have atrial fibrillation and don't even realize that their body is going in and out of it. One of the more common symptoms is having those palpitations, feeling like your heart is racing. It can also cause somebody to feel tired and fatigued. They might feel short of breath. They might also have some chest pain or discomfort in their chest. They might feel lightheaded since their heart isn't pumping effectively. They might have a decreased blood flow to their brain. It can also cause sweating, sometimes confusion. There's a whole variety of symptoms somebody with atrial fibrillation can feel, but again, it can also be asymptomatic. And also important to note that the severity of these symptoms can vary from person to person. Somebody might feel lightheaded, another person might pass out or have syncope due to AFib or another cardiac arrhythmia. There are also many causes of atrial fibrillation. Somebody may have AFib due to a heart valve disease, hypertension, heart failure, or cardiomyopathy, coronary artery disease, which can lead to heart attack. Some non-cardiac causes of AFib are certain types of lung disease like COPD, thyroid disease, particularly hyperthyroid. If somebody's thyroid is overactive, it can cause AFib and rapid heartbeat. And certain lifestyle factors like smoking, how much caffeine you're consuming, alcohol, other types of medications and drugs all can lead to atrial fibrillation. And there are some times when somebody has AFib and we can't find a reason. This is called idiopathic AFib. Atrial fibrillation is diagnosed with physical exam by listening to the heart or feeling the pulse, because since somebody's heart is disorganized and beating at an irregular rhythm and rate, you can hear that it is what we call irregularly irregular. This means that the heartbeat is irregular, but there's also no pattern to the irregularity. It's just completely disorganized. Your doctor will also check an EKG. This is a machine that checks the electrical impulses of the heart, and it will show us that the patient is in atrial fibrillation. There are certain things that we look out for, particularly that there are no P waves, and also you can see the irregular pattern of the heart rhythm on the EKG. A patient's physician might also recommend they wear a Holter monitor. This is kind of like an EKG, but more prolonged. An EKG typically just takes a couple minutes to set up, get the EKG, and then, take the leads off of the patient and have them leave. And that is just one snapshot in time of what the heart is doing. So you might capture the heart in a regular rhythm. You might capture an AFib, especially in people who have paroxysmal AFib, that they're going in and out of this heart rhythm. So if there is a high suspicion for atrial fibrillation and it was not captured on the EKG, the physician might recommend a Holter monitor. And this is usually for 24 to 48 hours, continuously recording the heart rhythm to capture irregularities, arrhythmias, and different events. And that is sent directly to the doctor so they can see the report of how often somebody's heart is going in and out of an arrhythmia. Some other things a patient's physician may check or an echocardiogram. This is an ultrasound of the heart. This is to look at the structural integrity of the heart and the valves. And they may also send the patient for blood work, especially if there is a high suspicion for a non-cardiac cause for AFib, such as hyperthyroidism. So why is AFib a concern? Atrial fibrillation can increase a patient's risk of heart failure or stroke due to the ineffective pumping of the heart. So somebody, particularly those who have paroxysmal AFib, where their rhythm is going in and out of AFib, it causes pooling of the blood in the atria, and this can lead to blood clots that can then travel to the brain. There is a particular structure in the left atria called the left atrial appendage, and this is a structure where clots are more likely to form and kind of hide out until they dislodge and travel to other parts of the body, particularly the brain, causing stroke. AFib also makes the heart work harder. So, like I said before, this is a risk for heart failure because the heart is being overtaxed. People with AFib are also at risk of other cardiac issues such as hypertension, which is high blood pressure, or a heart attack. So, how do we treat AFib? Well, one, if it is due to a cardiac or non-cardiac cause, then we treat the underlying condition. And the cornerstone of AFib management is rate control and rhythm control. So you want to control the heart rate, make sure it's not beating too rapidly. So we give patients typically beta blockers, which will slow the heart rate down. We also may use calcium channel blockers. These are two different classes of medications commonly used to treat atrial fibrillation. And in terms of rhythm control, we use antiarrhythmics, amiodarone being a very common one, sotalol, flecainide. And there are a couple of different antiarrhythmics that can be used to treat atrial fibrillation. People with AFib also benefit from being on a blood thinner or anticoagulation due to the stroke risk. If somebody has rapid AFib, poorly controlled AFib, or if AFib is causing them to decompensate, meaning that they have a low blood pressure, having evidence of organ damage, they may need to be cardioverted. This is when we use an electrical shock to convert their heart back to regular rhythm. In addition to anticoagulation, another way that we prevent strokes in atrial fibrillation patients are using something called a Watchman device. This is done as a minimally invasive procedure where they place a device that blocks off the left atrial appendage so no clots can escape from there. During open heart surgery, the surgeon may also perform a left atrial appendage ligation. And this again blocks off the left atrial appendage and a clot that may form in there from traveling to the brain. And finally, do I see atrial fibrillation in the ICU? Every single day. Critically ill patients are at high risk of AFib. AFib could be a sign that your body is critically ill. We will see atrial fibrillation in septic patients in septic shock, sometimes people in cardiogenic shock. Sometimes people will have poorly controlled AFib or AFib with RVR in conditions that are flaring up. So this is something that I see on a regular basis and need to use IV medications to control the heart rate, control the heart rhythm, and at times I need to perform cardioversion to shock the patient's heart back into a normal rhythm. I hope you enjoyed this video. If you have any questions about atrial fibrillation, please leave them below. If you want to learn more about the intensive care unit and other health topics, please subscribe to my channel. You can also follow me over on Instagram at TheIntenseMD. I'll see you next week with the next video.